Hello, I am Dr. Mugdha Raut, an obstetrician and gynecologist and a clinical reproductive immunologist. We have our centers, Dr. Raut's Center for Reproductive Immunology in Mumbai, Nagpur, Pune, Delhi, Bangalore and Hyderabad. Here we treat couples with unexplained repeated miscarriages, IVF failures and unexplained infertility with the help of lymphocyte immunization therapy, that is Immulit, which is our patented and branded process, and other individualized passive immunomodulatory treatments. Today, let's see preeclampsia and alloimmune rejection of pregnancy. Preeclampsia or pregnancy-induced hypertension is a pregnancy-specific heterogeneous vascular disease of the human pregnancy. It usually presents in a woman who is previously normotensive during the second half of pregnancy and is characterized by hypertension, proteinuria and edema, or preeclampsia associated without the signs of proteinuria. Preeclampsia is observed in 3 to 8% of pregnancies. It is one of the most significant causes of maternal and fetal morbidity and mortality worldwide. There is increasing evidence now that implicates the important role of the alloimmune problem in the etiopathogenesis of preeclampsia. Immunophysiology of pregnancy involves the study of the immune system, which plays an important role in maintenance of pregnancy. The maternal immune response during pregnancy is essential to maintain the pregnancy. The fetus possesses half maternal genes and half paternal genes, or from a donor male, making it a semi-allograft in the immunologically active mother. In case of donor egg or donor embryo, the pregnancy is a complete allograft. However, the fetus grows unabated in the mother's body due to the development of the immune tolerance by the mother's immune system. The more genetically distinct the fetus is, the greater is the immunological tolerance during pregnancy. This is known as the paradox of pregnancy. Now let's see the immunopathology of preeclampsia. Preeclampsia is a pregnancy-specific disorder characterized by hypertension and proteinuria and may progress to a multi-organ disease. The exact etiology of preeclampsia is still unknown. However, deficient early placentation is particularly associated with early onset preeclampsia, and this abnormal placentation is thought to be immunologically mediated. It is likely that preeclampsia results from abnormal trophoblast growth and differentiation at any time after the earliest stages of implantation. The primary dysfunction may be immunological, leading to 3 stages of preeclampsia or immunologic stages of preeclampsia. According to the immunological changes occurring at the feto-maternal interface, preeclampsia is divided into 4 stages. Stage 0, which occurs before conception. The absence of seminal plasma predisposes to non-development of maternal tolerance to paternal antigen. In the stage 1, which is seen in early pregnancy at 3 to 8 weeks of gestation, implantation and very early placentation happen, or histiotropic placentation. During normal pregnancy, there are immunoregulatory mechanisms at the feto-maternal interface which help in continuation of the pregnancy. This involves interaction between the decidual immune cells, that is the T cells, macrophages and the dendritic cell, and class 1 HLA mainly seen from the trophoblast. This happens due to allorecognition. If there is a total failure of the immunoregulatory mechanism, it leads to a pregnancy loss. However, a partial failure leads to continuation of pregnancy with defective placental process. This creates a continuum between abortion due to alloimmune cause and preeclampsia. In this process, tryptophan plays an important role. Indolamine 2,3 dioxygenase or IDO enzyme present in the decidual immune cells leads to the depletion of tryptophan by its catabolism. Depletion of tryptophan promotes the differentiation of Th17 cells to Treg cells, which then produce immune tolerance and continuation of pregnancy. Failure of the activation of IDO results in a pregnancy loss, but dysregulation of IDO results in poor placentation and paves the way to preeclampsia. There are no clinical symptoms or signs in this stage. In the second stage, which occurs in late first trimester and the early second trimester, that is 8 to 18 weeks, mainly involves abnormalities in placentation and there is defective formation of the cytotrophoblast, that is chorion frontosum and chorion levae, and syncytiotrophoblast. There is a second wave of placentation at this time and the dysregulation of the immune mechanism between the NK cells from the decidua and HLA-C from the trophoblast continues. There are no clinical signs and symptoms during this stage also. In the third stage, which is seen in the late second trimester and in the early third trimester, occurs post-placentation and it involves interaction between the cytotrophoblast, that is the chorion levae, and the villus syncytiotrophoblast on one side and the decidua and maternal blood on the other side. The poor placentation that has resulted due to events in stage 1 and 2 lead to the spasm of the small muscular spiral arteries leading to high pressure pulsatile flow to the intervillous space. Rapid changes in oxygenation and hydrostatic stress lead to endothelial damage. The resulting oxidative and endoplasmic reticulum stress leads to the inflammatory changes. In this stage, the disease process goes beyond rejection of the allogenic placenta and is characterized now by a global maternal inflammatory response to a damaged placenta. The inflammatory Th1 environment further suppresses the generation of T regulatory cells, leading to alloimmune tolerance. There are also trophoblast derived factors in the preeclampsia which play a significant role in preeclampsia. The maternal systemic inflammation, which is the hallmark of preeclampsia, is contributed by many trophoblast derived factors like activin A, corticotrophin releasing factor, leptin and free heme. However, the most important factor is the microvesicles and the nanovesicles released by the activated placental cells. There is significantly higher amount of micro and nanovesicles seen in preeclampsia. They are pro-inflammatory and have an anti-endothelial effect. The microvascular shedding from the syncytiotrophoblast increases in two situations. The first is when the placental size is large, as seen in twin gestation or large placenta in the late third trimester. In this situation, the onset of preeclampsia is in the third trimester. The second situation is when the placenta is damaged due to the inflammatory process caused by oxidative stress and the endoplasmic reticulum stress. This leads to early onset and more severe form of preeclampsia. In this case, the placenta may be abnormally small and associated with severe inflammatory process. Now, let's see the immunology of preeclampsia and in assisted reproductive technologies or ART. In natural conception, seminal fluid plays an important role in inducing immune tolerance even before conception. Exposure to seminal fluid induces the accumulation of Treg cells in the uterus prior to embryo implantation. Treg cells are essential in implantation. Use of donor spermatozoa increases the risk of preeclampsia almost 18 to 18.2%. Risk of preeclampsia in IVF and ICSI with ejaculated sperms is the same, 4%. But in ICSI with surgically obtained sperms, it is significantly higher, that is 11%. In case of ovum donation or OD, where there is previous exposure to the partner's semen and the fetus is a semi-allograft, the risk of preeclampsia is 16%. However, when embryo donation or ED is done, there is no previous exposure to the semen and the fetus is a complete allograft, where the risk of preeclampsia is very high, up to 33%. So in conclusion, preeclampsia is a dreaded obstetric condition characterized by complex immune mechanisms. It develops in stages. Before conception, stage 0, absence of seminal plasma predisposes to non-development of maternal tolerance to the paternal antigen. In stage 1 and 2, there is partial failure of the immunoregulation leading to poor placentation and abnormalities of uteroplacental perfusion. In the third stage, which is clinical, is characterized by systemic inflammatory response involving multiple systems. Use of donor gametes increases the chance of the development of preeclampsia, maximum being in embryo donated pregnancies as the fetus is completely allogenic and there is no seminal exposure. Thank you.